Dr. Payne is here. Dr. Lou is in studio for the next hour answering your phone calls. Okay, Thanksgiving's done. The turkey leftovers are all through. Now it's back to regularly scheduled business. So taking your calls, of course, 416-870-6400, star 640 on cell. Bring them on. You got pains, you got aches, you got treatment, not sure where to go, where it's coming from, where to be. Dr. Lou is here to answer all of your questions, and info at paincarecanada.com. You want to toss us an email as well. So what happened this week? Anything interesting? Got to be.
Yeah, there's always something interesting every week. This week I had a male patient who came in for about the last 6 months, has been having upper right quadrant pain, which is in the abdomen, so kind of below the left pec. And so in that area, anatomically, the biggest thing to consider is the liver is in that area. And patient obviously had already been to the family doctor for this. The family doctor thought this is probably something liver related. Drinks a little bit. That's another thing you would worry about with this type of history. He does have his occasional alcohol, but not an alcoholic by any means. So no big red flags. He is middle-aged, so you start to wonder a little bit more. And so he's having this upper right quadrant pain. The doctor believes it's probably something related to the liver. Okay. Does every test that you can imagine for the liver, including ultrasound to take a look at it, full blood work looking at all the liver enzymes. Everything comes back fine. They start to investigate further, go into MRI just to make sure, look at surrounding tissues, gallbladder, pancreas, et cetera, et cetera. Healthy as a horse, no issues whatsoever. Comes in to see me because he's heard us talk about the referral pain component of what we've talked about. And so I saw him, and sure enough, I did my thorough history. I also examined his abdomen and I examined his liver because there's some physical exams that you can do to actually palpate the liver. And again, there was nothing that was alarming that was setting off any issues for me. And I started to think of, okay, well, what are the other musculoskeletal components in that area? And one thing that often gets overlooked because it's underneath the liver is the diaphragm, which is a muscle that helps you breathe, which is kind of underneath your lungs. And as soon as I could get under there and palpate that muscle, he jumped through the roof.
No kidding.
Yeah, and he says, that's exactly the pain that I've been suffering with, and I can't get rid of it. And so then I started to talk to him a little bit more about when it would come on and when he feels it and doesn't feel it. And another thing that was pointed me towards the musculoskeletal issue is a lot of the pain is when he's lifting and doing things because he has a physical type job. So anyways, long story short is we end up treating his diaphragm. So there's different types of relief techniques that you can do for the diaphragm. We treat his diaphragm, and within one treatment is 80% better. Okay. And I've already seen him one other time. And so likely when I see him next week, he'll probably be 100% better. And that was something that he had been living with for 6 months and couldn't figure it out. But all because no one stopped to think that, okay, well, if there's no serious cause to the pain, then there must be a musculoskeletal component to the pain. And that's the important thing in assessing pain is you have to rule out the very serious things. There's a cardiologist that I know that will actually send, and a family doctor does the same things, because a lot of the times you can get angina, which is chest pain related to the heart. That's not actually related to the heart. Sometimes it's just musculoskeletal in nature coming from a rib. So these doctors, when they know that they've ruled out any cardiovascular component, will send it off to me once they're certain it's probably MSK, because they want someone who can deal with the musculoskeletal component and deal with it well. Can it go the other way? Yeah, absolutely. One thing that, similar to, since we're talking about the liver and the gallbladder in that area of the body, there was a patient that I had a few months ago, I guess at this point, who came in for right shoulder pain, top of the shoulder. I assessed the shoulder. In speaking to the person, I thought it was probably a rotator cuff issue. Assessed the shoulder in the physical exam. Nothing that I could do could provoke the pain. The key with the physical exam component is you're trying to provoke the pain that the people are complaining of.
Yeah, and does this hurt? Does this hurt? Does this hurt?
That's right. No matter which way I moved it, no matter what orthopedic test I did, no matter where I poked in the joint, whatever, nothing elicited the pain. And so one of the other things with right shoulder issues is that the gallbladder can actually refer pain to the right shoulder and not necessarily
crazy.
Not necessarily in the gallbladder. And so once I was certain that there wasn't an MSK component to the shoulder, I did an abdominal exam. And as soon as I started palpating in that area and I kind of got to where the gallbladder was and I poked, person almost jumped off the bed again. And so sent him off to, I suggested the family doctor. They wanted to go see the emergency room because they just thought it would be too long to get in. And turns out after they were there and had the appropriate test, just tons of gallstones, had to end up getting their gallbladder removed, and totally fine now. So yeah, I can go the other way as well.
So what is the link between an organ like a gallbladder and then running right up to your shoulder? How does that even work?
Yeah, again, it all comes back to the referred pain, and the way that I explained a couple of segments ago is there's only limited amount of nerves that come out of our spinal cord, and at every level where one comes out, it tends to go to different areas of the body, and it doesn't necessarily just go to something that's a muscle or a joint or stay consistent to that. Sometimes it'll also go into the visceral component, which could be an organ. So if there's a shared nerve path between an organ and some type of mechanical structure like the shoulder, well then if there's problems at either end of that nerve, you can get that referred pain.
And that must be all of it. It kind of goes back to what you were talking about last week with the acupuncture. I mean, you get a needle in your ankle, all of a sudden your jaw feels better.
Yeah,
it's really
exactly.
weird.
Yeah, that traditional Chinese approach to acupuncture for sure is very similar in that regard. That there's areas that just seem to neurologically correspond. Yeah.
We got lots more coming up. Your phone calls. We got phone lines wide open, 416-870-6400, star 640. On cell, you got questions, concerns. Dr. Payne is in studio till 1 o'clock this afternoon. It's the Dr. Payne Show on Talk Radio, AM 640. 12:12 on Saturday afternoon. Yeah, have physical concerns, maybe a diagnosis you're not sure of, can't understand it. Maybe you haven't been diagnosed yet. You need a quick opinion. You want some questions answered. Give us a call here at the station. Dr. Lou is here until 1 o'clock this afternoon. And outside of the show, if you need to get a hold of him, no problem. 1-855-55 Lou. That's DRLOU. Dr. Lou would be the number there. Let's talk about discussing the importance of treating acute injuries, not just letting them heal on their own, which is a lot of people choose to do, right?
Yeah, and I think that is easier understood when you can meet somebody and actually talk to somebody who has chronic pain. Because chronic pain ends up being something that was likely acute in the beginning, didn't get treated the right way or got dismissed, and becomes chronic. And when you meet a person with chronic pain, you tend to see how bad this can be, like how bad chronic pain is. It really is a disease, and it's again, this going back to how subjective pain is versus an objective measure. And when you can really divulge into that person's life, you can see how many aspects of that person's life it affects. And it's sad every time I see it. I've seen thousands now, and every time I see it, I'm still brokenhearted to see what these people are going through. And oftentimes these injuries are due to some acute injury that happened that didn't get treated the right way. And so as a population, and our bodies inherently have an ability to help to heal themselves. So it's not, out of uncommon to think that people think, okay, well, it's not that big of a deal. Let it heal on its own, and then it is what it is. But I would say that, if after 3 to 5 days, something's not feeling somewhat better, that's the acute point where you should say, okay, let me get someone to really take a look at this and get it treated the right way. Because a lot of times the body is faulty in that it can help things heal, but it may not necessarily heal it in a way that's conductive for living into the future, right? So once it starts to lay down too much scar tissue, or it lays down scar tissue in a haphazard manner that's the wrong way and doesn't allow that muscle to slide the right way anymore, et cetera, this can really affect the function and the pain levels of that area going forward, and that's a big problem.
So say you get someone who's much more long-term, started as acute pain at one point, now we're 3, 5, 10 years in, now it's chronic pain, now it's this thing's consumed my life for a decade. I don't see any light at the end of the tunnel. How do you begin breaking down that callus? Yeah,
that's where targeting the person's one of the things I like to do with my patients is really sit down and, again, have a comprehensive examination with them, which includes a comprehensive history and a comprehensive physical exam. And in that history, and then after I'm done those two things, I go through a plan of management. So I could be spending anywhere in that first interaction with a patient an hour to an hour and a half. The last component, the plan of management, is where I essentially suggest what it's going to take for you to potentially get better or get better than where you are. And once you get that type of person where they don't see that light at the end of the tunnel, that's a lot of where what I have to do comes down to education and advice and trying to change their way of thinking. Now, again, I'm not a psychologist and it's not my job to do these things, but that doesn't mean that I can't make the suggestions for people to realize, because I've said it to you before, when you have that type of thought process, you're now contributing it to yourself. If you're thinking like that, all you're doing is making yourself worse. You have to be able to say, okay, what can we do here? You have to be willing to open up and accept how you go forward. One of my first clinicians, and I think I've said this on the air before, when I was a student, the first thing that he ever talked to us about his group of students was, don't try to help someone more than they want to help themselves. Right. And that's a big component. And this is why a lot of healthcare professionals become jaded, because they try to do so much to help people. And it's oftentimes hard, and people don't actually want to go through with what's being recommended. And you end up caring more than the person who should be caring does. And so I try to take that approach where I try to make people understand you need to care about yourself, because if you don't care about yourself, who's going to care more about yourself?
I can't help you if you're not willing to.
If you're not willing to work at it, if you're not willing to help me help you, then how can we go through this? So you really, really have to start breaking down that barrier, which comes down to a lot of education and advice. And this is, again, one of the reasons why I want to be on the phone, on the radio, having this conversation with people, for them to hear this, because this is not something that's often talked about in healthcare, and people need to hear this. There has to be a component where people listening right now that have been suffering say, I need to make the difference. It's the same as people who want to lose weight. The biggest distinguishing factor is you want to or you don't want to, because everyone that I've ever met... You can
say you want to, but, proof's in the pudding, son.
Well, exactly. Right? And words are words, but actions to me have always spoken louder than words. So it's when you can use your actions, and that's always going to speak louder than words, for sure.
416-870-6400, star 640 on cell. Could take your calls. Got lines open. You want to talk to Dr. Liu, you can do so. This is another one, kind of leads into that, and the topic of patients constantly self-diagnosis, and they're sometimes unresponsive to healthcare, right?
Yeah. Well, it's dangerous, self-diagnosis, especially with all the resources that we have, which, again, pros and cons. I think having the resources is great, because a lot of the times after I'm done with a patient, I'll recommend some good resources that are readily accessible through the internet for people to take a look at. But I think there's a problem when people just type in a symptom and look at what it could potentially be, because they don't understand all the signs and symptoms that a patient presents with. One of the worst things that I have to try to get over with is if I help a woman, for example, with shoulder pain, and whatever the root cause of that person's shoulder pain is, and then they meet someone else that has shoulder pain, they'll say, go see Dr. Liu, because he helped my shoulder pain and your shoulder pain is the same. No, it's not. There's dozens of different things that can help, that could be wrong in that shoulder. And I appreciate the referrals, but I always want, and the first conversation I have in that instinct where the person says, yeah, Susie referred me and she said you helped her shoulder pain and mine's exactly the same. I always say, well, we don't know that for sure, and I hope that I can have the same outcome, but let's take a look at it, because there's different causes and you can't be self-diagnosing or understanding, because a little knowledge is a dangerous thing, especially when it comes to healthcare.
416-870-6400, star 640 on cell. Austin in Toronto. Hi, Austin. How are you? Hello, Austin.
Hi.
Hey, you got a question for Dr. Liu? Go ahead.
Yes, I do. I've got an ongoing shoulder pain problem, and I just kind of caught the end of what you were saying. There could be multiple causes for this. Mine started with my right shoulder blade about 3-4 years ago, and I spent a lot of time driving or riding my motorcycle or on the computer, so I kind of figured, people who are on the computer a lot, they get this upper back problems. So mine started as a right shoulder blade, and then eventually moved into my shoulder joint and then into my arm. It was really bizarre. It took a long time going to chiropractors, TENS machines, that sort of thing.
Mm-hmm.
That sort of gone away, but now I actually have a problem on my left shoulder joint.
Okay.
And that's been going on for a couple of years, and I've literally stopped going to the gym because there's nothing in the gym I could do with the pain I have in the shoulder joints.
Right. Have you had any treatment for that left shoulder similar to the treatment you had for the right shoulder?
No, I haven't. My GP says he made me lift my arms up forward, do some series of exercises, and he said it's an impingement.
Right. So again, the biggest thing I would say here is you've kind of said it yourself already, that on that right shoulder where you had an issue, you got some treatment and that got better. But now on this left shoulder, there's an issue. You went to see your GP, said there's an impingement. An impingement is something that needs some type of therapy in order to heal. So it sounds like that's what's missing, that if you're not doing any type of therapy to help that impingement to change the dynamics in that shoulder, well, then that's only going to keep going, especially with the types of things that you're doing in your day activities of daily living, like sitting at a desk, riding a motorcycle, if you're not doing anything to change the mechanics or remove that irritation, that once upon a time acute issue is going to start to become chronic. And as it becomes chronic, it's only going to be harder and harder to deal with. So I would say that if you haven't had any care done for it yet, then you should definitely try to get some care. Again, that's something that we can also help you, my team of at paincarecanada.com. For sure, there's ways that we can take a look at that and figure out what's going on and help you out.
In Austin, you can write this number down for you as well, 1-855-55-Dr. Lou. More of your phone calls coming here. Dr. Payne Show continues. Talk Radio, AM 640. 1224, Dr. Payne Show, 416-870-6400, star 640 on cell. And welcome, Maggie. How are you?
Oh, hi. I'm good. How are you?
Good. You got a question for Dr. Lou?
Just a quick one. I've been suffering with carpal tunnel for over a decade, more than a decade, probably more like 15 years. And it's now going into my elbow and my shoulder. And I'm just curious, does that mean I really need the surgery, or is there anything else I can do?
So, Maggie, who originally diagnosed, were you diagnosed with carpal tunnel?
Yes, with a neurologist.
A neurologist diagnosed you with carpal tunnel. And now what did you do to actually treat the carpal tunnel syndrome?
So originally, 15 years back, we had the braces for me, and they did work for 6 months every night. I had to wear them.
Mm-hmm.
Then it went away, it got better. And then over time, I developed love for knitting and crochet.
I'm sorry, say that last part again.
Sorry, I became in love with knitting, and so it came back with a vengeance, and it's just been getting worse and worse. I do wear my braces, but I just find I would literally have to wear them 24 hours in order not to have any numbness or.
Right.
But it's the pain now. I find it's getting.
Yeah.
It's in my shoulder now, literally.
Right. So one of the things with the misconceptions around carpal tunnel. We use that term, and what the carpal tunnel really is a tunnel
That's
within
a structure.
Yeah,
right?
It's a structure within the wrist where a branch of the median nerve passes. And if there's something going on in that tunnel, you start to get what's called a median nerve neuropathy. Now, the median nerve doesn't just start at the carpal tunnel. It actually starts up in your neck. So it makes a lot of sense that you may still have the same types of symptoms that are common with a carpal tunnel syndrome, which is an impingement of the median nerve at the wrist. But what's happening now maybe is you have an impingement somewhere else in that median nerve along the way, either at the elbow or under pec minor or in or the scalene muscle. So there's different structures that if they push on that nerve can cause those same types of symptoms. And it sounds like what's going on is probably, I mean, I can't tell speaking to you over over the radio exactly where that impingement is, but just the fact that you're saying now it's at the elbow, it's at the shoulders, what you probably have going on is there's multiple structures that are probably tight, impinging on that nerve, giving similar symptoms to what carpal tunnel would give, which is numbness and tingling in the first 3 digits. Right.
So where do I go from here?
So again, you would probably need someone to assess it properly to take a look at, okay, where exactly is that impingement happening? And likely it's not surgical. And so again, this is where I would say, give us a call at the 1-855-55-Dr. Lou number, and we can help set you up with someone, because I see you're calling from Grimsby.
Yes.
So we have a provider network across all of Southern Ontario, and we can help set you up with somebody that I personally think will be well equipped to help you figure out your problem and get it better.
That's fantastic.
Okay,
Thank
Maggie.
you so much. So what's the number again? 1-855.
1-855-55 Dr. Lou, DRLOU, Dr. Lou.
Gotcha.
All right, Maggie, you're awesome. 416-870-6400, star 640 on cell. That's why the phone call pays off. There you go. She got a little brighter at the end of that one. You wrote some notes here for me. This is interesting, and I want to discuss this. And please discuss pain for pleasure.
Ooh.
What are we moving in on here, boys? Leather, straps, what are we talking about on the Dr. Payne Show?
Well, no, I mean, the reason why I thought it's an interesting topic is because it highlights the psychological aspect of pain, which I try to talk about in order to get people to understand that psychology plays into your pain. And so one of the ways to highlight how important psychology is in pain is when you look at people who have a fetish for pain. And so
I don't have that fetish. I don't like pain.
You don't have that fetish. I don't really have that fetish either. And so, but there are people people out there that for sure, do
Yeah.
have a fetish for pain. And there's a psychological aspect where they enjoy that pain. And what does that do to that type of person who's suffering from a shoulder injury and it never gets better?
Right.
Because you have a component there where you like it, right? Or maybe you're using it as a crutch. When I say pain for pleasure, I also talk about things like secondary gain. A lot of the times I'll see people who, for example, might be off from work due to an injury. And one of the things I always start to talk to them about is what their job is like and how much they enjoy it. Because if someone doesn't enjoy their job, well, what's the incentive to go back to it? Right. And there's a lot of people out there. And so then there's a pleasure component to having that pain and using it as a crutch. And I also talk about it, like I said, in terms of a fetish. But, I'm sure there's people out there listening right now who have pain fetishes. Let's take those calls. I'd love to hear about it. It's a very interesting topic. And understanding that component will also help us to understand the opposite. How do we use psychology to help diminish people's pain? If
you have this pain fetish of which you speak, can it be dangerous?
Say that again, John. Sorry.
Well, can it be dangerous? I mean, you could be ignoring something that could be pretty bad for you, even though you've got some sort of
for
likeness
sure.
for it.
Yeah,
right?
for sure. Well, pain is a warning bell, right? That's why it exists for us, is essentially to tell us that something's wrong. So I think pain is something that needs to be identified. It needs to be made aware, and you need to talk to somebody about it so that you can figure out that there's nothing life-threatening, right? Like that's the big thing with pain, is you want to make sure that it's telling you that there's something wrong. And a lot of the times it's even the first symptom for some of the most deadly things that could happen to us as humans. And so it's not something that should be ignored.
Wide open lines. Give us a call. Yeah, if you're into that sort of thing, or if you've had some sort of discussion or experience with it, or any other topic for that matter here in the Dr. Payne Show. 416-870-6400, star 640 on cell. Got an email about plantar fasciitis. We'll get to that after a short break as well. Talk Radio AM 640. 1232, Dr. Payne Show, 416-870-6400, star 640 on cell. Yeah, someone just kind of wrote in quickly, and before we get to a call, describe and some details on plantar fasciitis.
And I see it says here, and some possible remedies for plantar fasciitis. So plantar fasciitis is a difficult one. We've talked about it before, where it's essentially the soft tissue at the bottom of the foot, and your foot is supposed to spring when you walk. And so if you have some type of irritation or minor tearing in that area, it's very hard for it to heal. The hard thing about plantar fasciitis is that we need to walk all the time. So when we have something like an elbow injury or a hand injury, it's a lot easier to put a brace on it or limit the movement. But as humans, when we have things happening to our feet, and not just plantar fasciitis, but any of the different types of things that can happen at the feet and the lower limb, it's a little bit more difficult because we need to use that even to walk around. I mean, even if you wanted to stay home and you still have to go into the kitchen or to the bathroom, you're still going to have to do it. One of the biggest things that I'll recommend with plantar fasciitis is the worst thing you can do is if you've been sitting for a long time or laying down for a long time, is just get up and go.
Really?
Warm that tissue up because again, if there are little micro tears in there, you don't necessarily want to put all of your weight and gravity on it and cause that tearing to expand. What you do want to do is warm that foot up, get those tissues loose, and then get going. That's one of the biggest recommendations with plantar fasciitis.
And how do you do that?
You could just do it yourself, moving it around, right? Like you could have a ball if you're sitting at the couch, have a tennis ball, roll your foot on top of it. It's keeping the tissues warm. Even a golf ball, if you've been in bed for a long period of time, you can kind of self-massage your foot, move it around, things like that.
Okay, we'll get to a phone call here when they come through the line. 416-870-6400, star 640 on cell. Tommy, get it lined up for us, and we'll take that one. We're taking anything you want to talk about as far as physio. You've had pain, you're suffering pain, all of that. We'll get to it. I got Chris in Toronto. Hey, Chris, what's up?
Hi, just a quick question. You talk about people that enjoy pain. What about self-harm, cutters, people that cut themselves, and it's because of a sickness as opposed to an enjoyment?
Right.
Yeah, for sure. And I think like that definitely needs to be something distinguished, where I'm talking about pain for pleasure. I'm talking about fetishes and not necessarily about self-harming or cutting that now goes into, suicidal things. And definitely I don't think necessarily those people that are self-harming or cutting are doing it for pleasure, but probably for something else going on. And that's totally different than pain for pleasure. But yeah, Chris, you're absolutely right. I think that's important to distinguish, and that's not what we're talking about. That we would never want anybody to be cutting themselves.
Chiropractic versus physiotherapy. Sometimes you see them in the same clinic. What's the difference?
Yeah, it's the biggest difference, I guess, is one of the problems with this conversation is that it goes jurisdiction to jurisdiction. So the scope of practice for chiropractors and physiotherapists in Ontario is different than, say, in Manitoba or BC, or even if you go down into different parts of the U.S. So it goes province to province and state to state. Scope of practice changes for every professional, because as a professional, you're licensed by your province or your state. So a physician is licensed by the College of Physicians of Ontario, right? So it goes down to that. In Ontario, since we're in Ontario, I'll speak specifically about that. The scopes of practice are pretty similar. The easiest way I explain it to people is that chiropractic and physiotherapy are the names of professions. A lot of what they can do is very similar. So one of the things people will often get recommended for physical therapy, but doctors will just say physiotherapy. So they're recommending to a profession. Physical therapy and physiotherapy are different things. Physiotherapy is the name of a profession, whereas physical therapy is an intervention done. So physical therapy. The same as when you say chiropractic, for example. Chiropractic is the name of a profession, but manipulation, which is often what chiropractors do, manipulation of the spine, is different. That is a different term. It just doesn't sound the same. So it really comes down to what it is that you need. There's different schoolings. I think it really comes down finding someone that you trust. And I know some great physiotherapists, and I know some very bad physiotherapists, and I know some great chiropractors, and I know some very bad chiropractors. So it really comes down to finding someone that you trust, understanding the difference and seeing how they treat, because a lot of the things that they do are very similar, and it kind of depends what you need. So, for example, let's say you just had ACL surgery and you need to do some rehabilitation. What's probably more important in that arena, in that scenario, is not necessarily should it be a physio or a chiro, but do they have the right equipment to help rehabilitate an ACL? And so both a chiro and a physio clinic could have that. And then also, let's say you do have a back problem and someone's recommended spinal manipulative therapy, the adjustments for the back. Well, then someone who has more proficient training in that, like a chiropractor, is probably someone more beneficial to do that. Having said that, there are physiotherapists who have taken extra training who can do that same thing. So it's a very blurred line here in Ontario because of scope of practice, very similar. The educational requirements are a little bit longer for chiropractors. They're classified as doctors here in Ontario.
I didn't know that.
Yeah, and most places around the world, whereas physiotherapists are not. But in some places in the States, they do have doctors of physical therapy. So again, it goes based on jurisdiction to jurisdiction and finding the right person that you feel confident with.
Is there a lot of scope of injuries where you could go either way in treating, meaning that both chiropractic and physical therapy could treat the same injury?
Yes, absolutely. And one of the hardest things, again, because I try to have this conversation with people, because people will say, I've been told that I need chiropractic care or I need physiotherapy
all the
care.
time.
You're just telling me the name of a profession. What type of care have you been recommended? So if an orthopedic surgeon, often the guys who deal with this stuff more like the orthopedic surgeons are a little bit smarter in their referrals, in that they'll say, okay, I recommend that the person get rehabilitation, electrical therapy, and laser therapy. They're very specific about the modalities that they want, versus the GPs are the ones that will just kind of say physiotherapy or chiropractic. And it's like, well, you're not specifying, because both of those people have a vast toolbox of different things that they can do. And again, this comes back to also the physiotherapist and the chiropractor. It's going to be their job to assess and make recommendations. But in a lot of instances, the recommendations could be very similar. Another thing with when you're dealing with Ontario is insurance companies often will give a certain amount of coverage per professional. So it may say $500 of chiropractic for this year and $500 physiotherapy. So sometimes if people don't have, disposable income and they want to utilize their benefits,
they're going to switch over?
They'll switch over.
Yeah.
And we do that a lot in the clinic, where someone may be seeing, say, the chiropractor first, and their chiropractic coverage runs out, and they'd love to keep seeing that person that they're used to seeing, but they understand that, money's tough and that they have these benefits, so they want to utilize that if they still need the care. We don't do anything where we say use it anyways. It's a matter of necessity. Totally. Do you need that care? And if so, then, the physiotherapist can continue with similar type of treatments, and and you'll still get the care. And we'll even go even further where sometimes there's coverage for acupuncture, so we'll get the acupuncturist involved. A lot of these paramedical professions overlap in terms of the way that you can treat.
We'll take a short one, 416-870-6400, star 640 on cell. You still got lots of time to call through. If you have any questions, physical therapy or otherwise, anything for Dr. Lou, he's here to answer them right up until 1 o'clock on the Dr. Payne Show. Talk Radio, AM 640. 12:43 here till 1 o'clock. Dr. Payne Show, Dr. Lou here to answer your questions. You can also email info@paynecarecanada.com. Anthony, big brother. You got an email you just came through, yeah?
Yeah, we do have an email.
Please share it with us.
Bill, who's contacted us before, his history of spontaneous pneumothorax in 2008. He says 8 years of misery, some good days, but some very unpredictable, countless medications, and he's been to a pain doctor who says just about put him underground, being a pill pusher. His chief complaint more recently is, I've got pain in my ribs on the left side, which is now radiating into my back on the same side. It gets very sore at night in bed and wakes me up. Some mornings I find it hard to move and get up. Any idea where the back pain would be coming from?
Yeah, and I think Bill has emailed before, he's even called in, and we've kind of discussed him with him a couple times on this. And this is where, when there's this much chronicity and that much of a psychological issue, the pain could be coming from anywhere at this point. That's going to be very hard to try to pinpoint.
Right.
But the one thing in order that I even recommended to Bill about trying to help his pain is the psychological aspect, really targeting the cognitive behavior therapy tailored towards pain management, where you start to use techniques like distraction, where you stop thinking about it, where you also start to minimize the importance of it in your life. It was actually interesting. I saw another patient this week, a girl, and her mom came in, and same thing, chronic issue, and a lot of it, she was sitting, it was classic. I could tell right away the psychological component to this little girl, and she didn't even realize it. I was speaking to her, and in speaking to her, I was kind of sitting next to her, not in front of her, and she had her body turned towards me, talking to me about her issue. And then I got her to get up, and I said, okay, I'm going to just check some range of motion of your back. I want you to bend forward. And she's like, no, I'm not going to bend forward. Okay, well, you were sitting in a chair, which is bending your back right there. And then I said, okay, turn to your left. No, I can't turn to. So she didn't want to do anything. And what that highlighted was something called fear avoidance behavior, where you have this, and this is where cognitive behavior therapy, what they'll try to do is, what was her belief? Her belief was that I can't turn because it's going to hurt. Well, the reality is you were just sitting in a chair in a bent posture at the hips with a turn. And you were fine in that chair. Right. So you need to start changing the unsubstantiated beliefs that you have in your mind with factual information that says, okay, I can turn and I can bend and it's not painful. You can't just be afraid to do it. That fear avoidance hinders prognosis, and it hinders people's abilities to get better. And this is something that's not a physical problem. It needs to be identified from the psychological component, where people need to start changing the way that they think about their pain.
You obviously, and I've gone through CBT myself with a clinician. It's fascinating stuff. I mean, it takes time to work, and it's like you said at the start of the show, you got to dedicate yourself to it, and it does work. It doesn't involve pills most of the time. It's great stuff. So in that regard, you obviously know people that can treat people in that regard. Is it often CBT comes after they see you, or they come before?
I think it depends on the specific case. There's times where it's in conjunction. There's times where it's after. And there's sometimes where they don't even need me at all, right? Where there's no physical component whatsoever. They just need the CBT. So it really goes case to case, where you need to look at that and really see, like, someone like Bill, based on what I've heard that he's done all the other things, this is the type of case where the CBT, and again, I'll encourage Bill, give us a call. We'll help you find someone who can help you in that regard, so that way you can actually get better. Because a lot of these things, when you've exhausted all the physical type of options, all the medications, the surgeries, et cetera, the only thing left is the mind. Right. And so, and again, that's not to suggest that in doing that CBT, you're ever going to be 100% better. But I think most people that are suffering from extreme pain like this, what I've heard anyways from the patients that I've seen over my career, is that they're very realistic. They come in and they say, listen, I'm not expecting to be pain-free forever. I would just love that if I could get, 2 or 3 hours in the day where I could still enjoy a round of golf, or I could play with my grandkids. I'd be happy. And so that's a big thing that I speak with and that my team speaks with our patients is realistic goals. What are your goals, and what are the realistic goals that we can achieve with therapy? And therapy not meaning just physical, the whole encompassing therapy. Because again, if I believe someone needs surgery, they're going to go see a surgeon that I know that needs the surgery. If they need medication, they'll be getting the medication. But what's important is that you have to look at this person. You have to highlight, okay, what is being done, what's not being done, and look at pain like, there's many ways to treat it, and you have to target it a little bit from each of those components, especially when it's a chronic issue.
416-870-6400, star 640 on cell is the number. We spoke about this a couple weeks ago. I want you to touch on it again, the importance or lack of importance of posture.
Yeah. So I'm a big believer that's what is more important is, are there more optimal postures? For sure. There's things that are more optimal. Are they realistic for long term? Probably not. So the example is, you get a person who sits at a desk for work and they say, okay, I need good posture. I need a good chair that keeps me in a good posture.
Right.
Well, you can have the best chair in the world that keeps you in the best posture, but if you don't get up and move around and be dynamic, you're still going to have pain, because our bodies are built to move around and be dynamic. We need to let go. Once upon a time, when people used to suffer from low back pain, the doctors would say, go home and lay in bed. And they found that the outcomes were worse and worse because these people were just laying down and the muscles were seizing up. And then once they were finally getting up to do anything, everything was going wrong. Now that never happens anymore. We recommend people, even in the first acute phases, to actually move around and do things because of how important it is. It has to be structured, and it doesn't necessarily need to be aggressive movements, but you need to move around. And the same thing goes with posture. Are there more ideal postures than not ideal postures? Absolutely. But the biggest thing and the easiest thing for people to remember is get up and move around and change what you're doing. Even if you've been walking, it's important to sit down then, right? So the opposite. Good posture doesn't just apply
No
to
posture is the best posture.
That's right. No posture, being dynamic is the key.
416-870-6400, star 640 on cell. Got some more time. You want to call through. You have questions. Something physical going on in your body. You're not sure exactly what is happening. Maybe Dr. Lou can help you out in the Dr. Payne Show. We'll take your calls coming up after a short break. Talk Radio, AM 640. It is 12:53 here on the Dr. Payne Show. We'll take a call. Christine, good afternoon. How are you?
Hi, I'm great. How are you?
Excellent. You got a question for Dr. Lou? Go ahead.
Yeah, I'll try to keep it short and to the point, and I'm kind of long-winded, but yes, for the last 4 months, on and off, basically every day now, though, what's concerning me is both of my pinkies on my hands, obviously, from where I go to bend, I go to bend them from the knuckle down is like hurting me every morning. And what really concerned me more so than just that is the other day I was trying to take some dishes. I had 4 plates and I was trying to put them away in the cupboard and I almost dropped them because my pinkies are starting to really hurt me. So I just started wondering I haven't gone to talk to nobody about this yet because I'm kind of got a bit of a pride issue being a mom of two and whatnot. But if you can help me, point me in the right direction, then that'd be great.
Yeah. Can you tell me the pain in the pinkies? Is it pain? Is it numbness and tingling? What can you a weakness? Can you describe it a little bit better?
Okay. I guess weakness, yes. And then in the mornings, obviously it hurts the most.
Yeah.
And I'm going to say this wrong, rheumatoid arthritis runs on my mom's side of the family.
Okay.
And a couple of my aunts started experiencing similar stuff in their, I'm 38 now, but in their 40s or whatnot. But I constantly use my, obviously, hands all the time. So.
Yeah, so there's multiple things. One of my questions would have been a history of any type of autoimmune disease like rheumatoid arthritis. So that's definitely something that you'd want to rule out right away. That it's not something that's rheumatoid in nature. The other potential is similar to the other person that we had call about carpal tunnel. You can also get the tunnel where the ulnar nerve passes can get irritated, and you can get these similar types of symptoms. And the ulnar nerve, the median nerve, which we spoke to the other person about will refer into the first 3 digits, whereas the ulnar nerve will refer pain into the last 2 digits. So the ring finger and the pinky finger. So if when you're waking up, if you're feeling this stuff and the symptoms you're describing, like when you talk about weakness, that's more of a neurological symptom versus an autoimmune system. So I would lean more towards, it sounds like it's due to the nerve, and the nerve's probably being impinged because it's on both sides. I'm going to assume it's higher up, like in the neck. Maybe you're sleeping the wrong way, or you've changed something recently and that's causing those nerves to get aggravated. But Christine, like I said, I think you're right. You do need to get it looked at. And I think the best place is to, again, give us a call. We have people up in Barrie, I see you're calling from there, that can help take a look at this for you and quickly figure out what's going on and get it treated the right way. Because definitely, if it's been a little bit of time now, you don't want it to keep going more than it has to.
Thank you very much.
No problem.
And I have been listening to the show for the last actually 2 hours. And when that lady did call in about that, I'm sad for her, but I was getting to the root if anyone else had this, because it's getting to the point where it's ridiculous. And I have both of my kids natural, so if you know where I'm going, so something like this, I'm like, oh, it'll just fix itself.
Yeah,
you know what I mean? But I'm not an idiot.
Are your kids still young, Christine?
Aaliyah's 5 and Austin is 13.
Are you holding the 5-year-old a lot?
No.
Okay.
No.
Because that may have been another, because that can help tense up the muscles and stuff. But I mean, it definitely sounds like it's more musculoskeletal in nature, where probably some muscles impinging on the nerve. So again, we can definitely help you figure this out. And, we started the conversation this morning about the pride factor, and I get what you're saying as a mom, the natural births. But remember, this is for the benefit so that it doesn't become a chronic issue. Just get it taken a look at. It's probably something that's not overly complicated to get better, and it'll make the world of a difference for you.
Call this number, Christine, you got a moment, 1-855-55-Dr. Lou. Got Lauren. Hi, Lauren.
Hi, good afternoon.
Hi.
I'm so happy I've been able to get through to your show. Okay, I've got a little problem. My left hand, I'm having a little bit of numbness, from the pinky finger and the second finger. Mostly when I sleep at night, if I should put my elbow onto my pillow and kind of thing and sleep, I feel like if there's circulation cutting off in my finger, the palm of my hands from those 2 fingers. What I have to do, I have to take it out and put it by my side straight, and I kind of feel a little relief from that.
Yeah. So what's probably happening, similar to a couple of the callers that we've had now, is you're sleeping a certain way that you're probably putting pressure on the nerve. And when you put pressure on the nerve, everyone's done this when they were kids sitting in an assembly hall watching something at school, when you're sitting cross-legged and your leg goes numb. That's exactly
pins
the same.
and needles.
Yeah, pins and needles.
Yep.
And the first thing that happens is it goes extremely numb. Then you'll start to get pins and needles. Then there's kind of a painful sensation, and then you're fine. And so similar types of things can happen when you're sleeping and you're sleeping the wrong way. You got your arm a weird way. The nerve gets impinged. It cuts off the nerve supply. It goes numb. You wake up because your hand is numb.
Yep.
You move it. It starts to get numbness and tingling. And then all of a sudden it's better. So there's probably, again, something going on in the way that you're sleeping. There may also be, depending on your life, the things that you're doing, a chronic muscle that's tight. That's just more tight when you're sleeping. And again, this is where these are the very, very easy things to get looked at right away, get solved, doesn't become a chronic issue, and it's very easy to solve. Give us a call for sure.
Okay, one quick thing, very, very quick. I can feel if I were to play around my elbow area where the nerves and tendons run, I can feel that sensation in my finger as I rubbed it a little bit.
Yeah.
And I can feel it cutting off.
Exactly. There's components where the nerve passes through certain muscles, and you're probably touching the muscle or the nerve where it's getting impinged, and you're feeling the referral pain down the nerve. And so, again, you need to release that muscle probably, and that'll probably help the issue. So, yeah, give us a call. We can definitely help you out.
Done for another week, my friend. Lots of information. You didn't get a call in, no problem. You can do it after the show. It's 1-855-55-Dr. Lou, DRLOU, 1-855-55-Dr. Lou, or email is info@paincarecanada.com. Till next week, and actually, no, Monday, you're going to be on the Insurance and Injury Law Show with Savannah, so that's going to be pretty cool.
That's right.
So we'll catch you Monday
and
before next weekend.
With us next week.
Next weekend. Look at you guys. It's a big kumbaya moment around here in 640 Toronto. We'll get more of that next week. Until then, this has been the Dr. Payne Show on Talk Radio, AM 640.